Hello. My name is Stavros Kavouris. It's my pleasure to be here today. Thank you for coming. This is the first out of a series lecture that we will have this semester, and following the next semester, it's a hydration lecture series. Today I have the pleasure to introduce Dr. Crandall, who's coming from University of Texas Southwest Medical Center. He's an expert on thermoregulation. I don't want to make him feel uncomfortable, but he's really a very significant person in the body of literature in heat physiology. He's associate editor in Medicine and Science and Sports and Exercise, which is American College of Sports Medicine official journal. He's associate editor in APS, Journals, American Journal of Physiology, Journal of Applied Physiology. So without further ado, I would like to get Dr. Crandall the microphone.
Thank you very much. Thank you, Stavros. I've really appreciated the invitation to come here. I express gratitude to you as well as to the department and to the university. It's a great opportunity to be here. Looking forward to the chat. I do want to make this comfortable so that you can feel like it is a chat. And that is, if you've got questions, please feel free to stop, raise your hand. I don't need to get through a certain amount of literature or material. Stop, raise your hand, and I'll be happy to answer the question as best I can. Because this is being broadcast, I will need to repeat your question so the individuals can, somewhere, wherever they are, can hear. So let's go ahead and start. Let's look at the title first off. Control of skin blood flow during hemorrhage, a choice between heat dissipation and blood pressure control. So I want you to think a little bit about under what scenarios can you imagine that heat stress could be combined with hemorrhage? Like an odd combination, aside from they both start with the letter H. So let's think about this. Let's talk about this. What about construction workers? I imagine that your climate here in the summer is probably fairly different, fairly similar to our summers in Dallas. It gets extremely hot. I'm amazed at these individuals that are putting roofs on houses in the middle of August. Just incredible. Of course, construction working, you would have a higher incidence of injury that might cause a hemorrhagic challenge. Unfortunately, you can't see this really well here. This is a police officer, and as many of you know, they'll wear body armor underneath the uniform. The uniform is often a polyester type material, and clearly they would have a higher incidence of both heat exposure as well as a hemorrhagic challenge. I love this picture, and once again, you can't see it very well. This is a firefighter. His face, really his whole head is extremely red. It's really clear that he's hyperthermic. He's got his fire trousers down around his ankles as he's getting his blood pressure taken. And clearly these individuals have a high incidence potential of a hyperthermic injury as well as a hemorrhagic challenge. But perhaps the most obvious scenario would be the modern warfighter. So here we've got an individual. This is a photo from a paper. This is a technical report paper by Bueller called Thermal Work Strain During Marine Rifle Squad Operations in Iraq. So some investigators said, we want to know how severe the heat stress is for soldiers in Iraq. And so during the summer months, they monitored conditions. Environmental conditions were 39 to 47 degrees C, or 102 to 117 degrees F, very low humidity, and all the soldiers were dressed like this. Of course, they've got ceramic plates in the way of body armor, clothing from really ankle to wrist, headgear, and obviously soldiers have a high incidence of hemorrhagic or hemorrhage. So let's take a look at some of the responses that were observed in these individuals. They went on a foot patrol of approximately 100 minutes in duration, and take a look at this. The load that they were carrying was 85 pounds. That's pretty impressive. If we look at the core temperature, now it's a little bit difficult because they instrumented these individuals at the base, then they went out to the site, and then they did their walk around, and then they came back to the base. And so we don't actually know what their temperature was before they left the base. This is the temperature within the first 10 minutes after they got out of the vehicle at the field, core temperature was pretty normal, maybe a little on the high side, 37.4. But after 90 to 100 minutes, it increased by about 1.4 to 1.5 degrees C. Skin temperature is on the high side. We know skin temperature is typically around 33 to 34, and notice it's upwards to 37 degrees. And that's probably because transport in these vehicles, particularly if the vehicles aren't air-conditioned, that could be a problem. And then it increased up to 38. Heart rate's a difficult one. Because, you know, if you're going out to the middle of Iraq with all your gear on, potentially being shot, I mean, how much of this is an emotional driven as opposed to a thermal? So that's a challenge. But you can see here that, likewise, heart rate is elevated to about 150. I have no idea what that little squiggly mark is there. It's about 150 beats per minute. So how do we simulate this? How do we duplicate this in the laboratory setting? Oh, I'm sorry, I jumped ahead of myself. I want to impress upon you that not every soldier is out walking around doing foot patrols, but there's a variety of responsibilities. And in fact, when I talk to soldiers, often, majority of the time, they're just sitting around. They're not actually on foot patrols. So here we have a gunner, and you can see he's going to be exposed to the heat of the environment, to the radiant heat. And so I don't want you to think that all the heat stress that these individuals go through is an exercise-induced heat stress, but there's also a lot of passive heating that's occurring as well. So how do we simulate this into the laboratory? Well, some of you may have seen this. Dr. Gagnon has one of these suits. This is a water-perfused suit that the individual place on them. Notice all the little tubes in this suit, and we can take water and then heat it up, or cool it if we want, and perfuse it through this suit, and then control both skin as well as internal temperature. And we can clamp it if you want to keep it at a certain level. We can make it transient. We can increase it or decrease it. Really do whatever you want to do. And measure internal temperature. There's a variety of ways of doing that. We use a core temperature pill, which is this little receiver here. It's a little pill that the individuals swallow, resides into their intestines, and it transmits the temperature. And for what I show you today, most of the increases in temperature will be comparable to what we saw in the field. That is approximately 1 to 1.5 degree C increase in internal temperature. We could measure skin blood flow and sweat rate at various locations. So this is a standard protocol that's used in many labs to heat stress individuals passively. So what happens when we do this as far as the cardiovascular system is concerned? This is some classic data by Larry Rao, in which he recorded cardiac output, heart rate, and stroke volume when he heat stressed individuals much the same way that this fellow here. And by the way, they're all very happy like this with heat stress. If you don't believe me, go visit Matt, and he can you put the suit on, and you can see what a wonderful experience it is. So here Dr. Rao recorded blood temperature, which started about 36.6, and increased it to about 38.8. So his ending temperature was comparable to what Bueller saw in these soldiers in Iraq. So cardiac output starts about 6 liters per minute, and as the heat stress progressed, it was about 122% increase. And let's just say 100% increase. That is cardiac output is going from 6 liters per minute up to 12 liters per minute. And that's very impressive. In fact, I can't think of any other non-pathological state that could cause, aside from exercise, of course, that could cause such a large increase in cardiac output as opposed to heat itself. So how does this increase in cardiac output occur? Well, here's heart rate being 67 beats per minute, and it likewise increases 122%. With stroke volume, the lower panel here, really not changing. So the take-home message here is that you get a huge increase in cardiac output due to this heat stress. And likewise, these soldiers are having a huge increase in cardiac output that's driven primarily by the increase in heart rate. So I want you to think a little bit about this. If cardiac output is going from 6 liters to 12 to 13 liters per minute, that blood has to go somewhere. It's not just going to disappear. It's got to go somewhere. And let's talk about places that blood is going to during this heat stress. Where is it going? So first, the splanchnic vascular blood. Now, that you think of this as the gut. This is the stomach, the intestines, the pancreas, the liver, etc. And the anatomy is really cool with this splanchnic bed. Notice that these are all here in parallel, and then they go through the liver, the blood flow, and then it exits out into the venous system. So if you give a chemical that's rapidly taken up by the liver here, you can look at the rate of blood flow through this splanchnic bed, which is what Chris Minson did with Larry Kenny a number of years ago, where they looked at splanchnic blood flow when they heated individuals. Here's esophageal temperature is what they used. So they heated individuals upwards to 38 degrees C. Blood pressure was well maintained. So what do you think happened to splanchnic blood flow? Well, we know cardiac output went up by 6 liters. It's got to go somewhere. So perhaps there was an increase in splanchnic blood flow. Well, not at all. And in fact, quite the opposite occurred. Splanchnic blood flow in these groups was about 1,400 milliliters per minute, and it decreased not quite 50%, maybe 40%. So there was a large reduction in blood flow to this bed during this particular heat stress. Okay? What about the renal bed? Maybe we know that the renal bed receives about 1 liter to 1.2 liters per minute. Maybe that's where the increase in cardiac output is going with the heat stress. Using a similar approach but with a different drug, you can look at the flow through the renal vasculature. Same responses here as far as temperature and blood pressure, and likewise renal blood flow decreases during heat stress on the order of 20 to 30%. So we know now it's not the splanchnic, we know it's not the renal. Maybe it's the brain. The brain blood flow is about 750 milliliters per minute. Perhaps some of the increases in cardiac output is going to this vascular bed. Well, one of the ways that we can measure brain blood flow is through a technique called Transcranial Doppler, where we take a Doppler beam, I'll use this laser, and shine it right in through the temporal window into what's called the middle cerebral artery, which is right here. And the signal that we get is very similar to a blood pressure signal. And in fact, from this we can estimate cerebral perfusion to see what happens to brain blood flow during such a heat stress. We did this, Thad Wilson did this a number of years ago in our laboratory. Here we have normothermia on the left, heat stress on the right. I think there's 27 subjects here. And what's obvious is that there's a reduction in brain blood flow associated with this heat stress. Pretty small. This was a pretty minor heat stress. We repeated this with Matt Brothers a number of years later, and we saw a 33% reduction in brain blood flow to the heat stress. So, going back to this, actually, I've jumped ahead again. Central blood volume. Central blood volume, that's the amount of blood, if you will, that's in the chest. And we're quite interested to what happened with central blood volume. Some of the early work by Larry Rao suggested it actually increased. And we were questioning that. It seemed odd to us that central blood volume would increase during a heat stress. So we took the opportunity to go into a nuclear medicine clinic and gave a drug called technetium. It's radiolabeled, and that binds to red blood cells. So wherever those red blood cells go, you can look at it and identify it through this gamma camera. So we place individual in the gamma camera, give the technetium, and we get some really cool pictures that look like this. The camera actually is two. There's a front camera and then a back camera, and that's what you're seeing here, is a front image as well as a back image. And this is while the individual is normothermic. And wherever you see dark or a higher density, that's higher blood flow, or higher actually blood volume, not flow. So if you look at the heart, the spleen, and then likewise the spleen and the heart and the lungs under normal thermic conditions. So I'm going to come back here to cycle this back and forth so you can see this. For example, take a look at the spleen under normal thermic conditions and then in the heat. Can you see how that density has changed? Here's normothermia, here's heat. There's a reduction in the density, and that means there's less blood volume in that area. Look right in here in the lung region, or if you will, even in the heart. Normothermia, heat. It should be obvious that there's this reduction in volume of blood going to the chest and to these vital organs during this heat stress. on the order of 15 to 20%, which is fairly significant. So let's go back to our quandary here. If we're increasing cardiac output 6 liters per minute, where's the blood going? And I hope most of you probably thought about this already. And of course, we've ignored the skin. Skin blood flows, normal thermic levels, is around 300 to 500 milliliters per minute. But it has a huge capacity to increase blood flow. It's got this vast plexus up here, extremely vascularized, and under the right conditions, you can see very large increases in blood flow. And in fact, heat stress increases blood flow to the skin upwards to 6 liters per minute. It's been argued that 100% of the increase in cardiac output during a heat stress is going to the skin. And of course, the reason for this is to adequately dissipate the heat. It's a very effective mechanism when combined with sweating. So, if we summarize the vascular responses that occurs during heat stress, we see a decrease in brain blood flow, an increase in cardiac output, but importantly, heart rate is quite high. Blood pressure, for the most part, is well maintained. Our splenic and renal blood flows are reduced. There's a reduction in central blood volume, and a very, very large increase in skin blood flow. Now, this is the scenario that the soldier is in when they are shot and hemorrhaging. And think about some of the mechanisms that you want to have to maintain blood pressure at a time when you're hemorrhaging. You want to increase central blood volume, but look, it's already low. You want to increase blood flow to the brain, but even before you're hemorrhaging, it's already low. You want to increase heart rate. You can't increase heart rate too high because it's already elevated. Your reserve to increase heart rate is reduced. And you're going to want to constrict the splenic and the renal beds, but they're already constricted. So your reserve is likewise reduced. This places a significant stress on the hemorrhaging individual who is heat stressed because many of the counter-regulatory mechanisms to preserve blood pressure are already compromised before the hemorrhagic injury occurs, resulting in a much greater incidence of hemorrhagic injury or death when somebody is heat stressed relative to when they're normal thermic or cool. And we're going to spend some time talking about some of the mechanisms why that might be the case. Well, how do we simulate a hemorrhagic injury in an individual? If you want to look at this question, you need to be able to replicate this, what's occurring as best you can, not perfectly, of course, in the field. So, you're not going to let me take out 2 liters of blood, are you? You just, that's just not going to happen. So we really can't look at the question that way. But you think about it, a soldier who is hemorrhaging, they're bleeding, and that blood, if you will, is spilling onto the ground, or perhaps in some other region in the body, maybe in some cavity or whatnot. So we need to replicate that as best we can, and we can use something called lower body negative pressure. And that's what this box is right here. It's a box that we seal at the waist. This door here shuts, and we apply a suction to it. It really is nothing more than a vacuum cleaner motor. We apply a suction to it, and that pools blood from the chest down to the leg and keeps it there. It stores it there. It would be just like us pulling blood out of your vasculature and putting it in a bag, but rather than in a bag, we're storing it in your legs. Or, if you will, it's like the soldier who is shot and bleeding, and rather than that blood going into the ground, we're just temporarily storing it into the legs. And we can progressively decrease central blood volume through the amount of suction that we apply to the point that the person faints if we choose to go that far. We typically don't, at least not on purpose. And to show you this, we've done this lower body negative pressure inside the gamma camera using the same techniques with this technetium. And here we have, under baseline conditions, just look at the heart itself. And this, you don't need to worry about the numbers. These are just graded levels of lower body negative pressure. Take a look at the ventricle. Can you see how the density is much less on the far right relative to the left? This is just showing you that we are causing this central shift of blood from the chest into the legs. and allows us to model a hemorrhagic state in these individuals. I really want to hit home this point, that heat stress compromises blood pressure control to a hemorrhagic challenge. I touched upon that a moment ago. When somebody is heat stressed, we know that their ability to regulate blood pressure is not as effective. And any one of you have probably experienced this before. If you've been lying out in the sun in summer, and then you stand up real quick, you feel a little bit woozy. That's more likely to occur when you're hot than if you're cold. And likewise, we propose that a soldier who is shot and hemorrhaging when they're heated are more likely to die when they're warm relative to when they're cold. This is illustrated here. We've got a blood pressure tracing at the top, and this red line right here is where we started this lower body negative pressure. This is just a wooden box that we're using to accomplish the same objective. We call it LBNP. So here's the blood pressure tracing. Everything's just fine as we progressively increase the amount of suction and this blood being pooled to the legs to the point at which blood pressure plummets. We call this presyncope. We don't want them to faint, but they feel miserable. They feel nauseous. They feel anxious. They're sweating profusely, often, particularly if they're normothermic. Of course, they're heated. They're already sweating. Blood pressure can be as low as 60 over 40 millimeters mercury. That's not uncommon, particularly if you have an arterial catheter, which we do in many of these studies. Now, the lower figure here is a survival curve. It's a way that we can express how well the individuals, if you will, survive the LBNP challenge. So 1.0 means 100% of the individuals tolerated that level of lower body negative pressure before reaching this point at which blood pressure crashed. And if we go across while they're normothermic, which is this black line, we can see that every individual survived 50 millimeters mercury lower body negative pressure. We lost 2 individuals at 60, another 4 individuals at 80, and then we lost the last individual at 100. I don't know if anybody has some batteries, but we could use some two AAA batteries would be very helpful right now, or another pointer. So that's what happened. That's the model as to what occurred under normal thermic conditions. And what do you think happens during heat stress? Well, we see a significant leftward shift of this curve. So whereas every individual survived 50, in this case, one person went out at 20, a bunch went out at 30, 40, and 60. And yes, to answer the question that you have in your mind, this person that lasted 100 is the same person that survived 60. So there's something interesting there with respect to your ability to survive a hemorrhagic challenge when you're heat stressed. The point is, there is a significant leftward shift of this particular curve, emphasizing the point that I wanted to make before, that heat stress compromises the ability to regulate blood pressure when you have this translocation of fluid away from the chest, as which occurs during a hemorrhagic insult. So, I want to spend some time talking about some of the mechanisms associated with this. Basic physiology. Blood pressure is equal to the product of cardiac output and systemic vascular resistance. So, if cardiac output decreases, which we know that it would during a hemorrhagic challenge, because if you're shot, once again, and you're bleeding, your cardiac output, or the amount of blood going back to the heart, is going to decrease, and you're going to reduce cardiac output. But if you want to maintain blood pressure, can you see that you need to increase systemic vascular resistance? And in fact, if you increase systemic vascular resistance proportional to the reduction of cardiac output, then your blood pressure is going to be well maintained. And the way that we increase vascular resistance is, of course, vasoconstricting the blood vessels. So that's an extremely effective and very important mechanism for us to regulate blood pressure at a time when cardiac output is reduced. So I'm quite interested in identifying this relationship and how it might be affected by heat stress. So we went back into the laboratory. Let me point out here. I'm very interested in identifying what happens to systemic vascular resistance. Now, we can't put a gauge on somebody and say, okay, this is your systemic vascular resistance. You can't do that. But you can with blood pressure. We can stick a little tube inside your artery and connect that tube to a little pressure transducer and measure blood pressure. And we can measure cardiac output through a variety of mechanisms, and from that we can calculate what happens to systemic vascular resistance. And this is exactly what we wanted to do, and Matt was very much involved, Dr. Gagnon was very much involved in this protocol. In fact, he was the lead author on the paper that came of it. We wanted to use a technique that accurately and had it with a high degree of fidelity measures cardiac output, and then calculate what happens to systemic vascular resistance under heat stress scenarios when cardiac output is reduced in this simulated hemorrhagic state. So, went back to the lab, same thing. Here's this lower body negative pressure. Here we go. Perfect. Thank you. Our laser is getting a little weak. Yeah. So we did the same scenario. We put them in the lower body negative pressure box. We applied the suction and we measured cardiac output. And the way we measure cardiac output is through a technique called thermal dilution. Thank you. There we go. We're back. Thermal dilution. This is a really interesting technique. Unfortunately, you can't do it in most scenarios. You need to have a medical setting, and I think you'll understand why. We take a catheter and stick it in a vein in the arm. We thread the catheter up into the superior vena cava, into the right atrium, into the right ventricle, out through the pulmonary artery, and then it resides into the pulmonary vasculature. And we can inject a bolus of cold saline right about here. And then at the end of this catheter is a little temperature probe, a thermistor. And the system, a computer, can calculate the flow through this heart by looking at some of the dynamics, thermodynamics of this cold bolus of saline going from the atrium to the lung. So if you think about this, yes, sir. Yeah, sensors. The question, are there multiple temperature sensors on this? There is a temperature sensor at the injection port as well as distal to it, but just 2 sensors, correct. And this is used very standard in just about any ICU situation. And if you can imagine, if cardiac output is really high, that cold saline will really rapidly get to the sensor, whereas if cardiac output is really low, it will take a long time to get to the sensor. The point is this is a mechanism or approach that we can very accurately record cardiac output, which has been a problem often in heat stress scenarios. Busy slide. Disclaimer, I apologize for I could not come up with a better way of describing these data. So please be patient with me as we walk through the slide. We're going to first talk about the parameters. This is heart rate up here, stroke volume, the next one down, and cardiac output to the bottom. And I realize some of you might not be able to see this. In fact, I am even having a hard time seeing this. Arterial blood pressure here, and here's our calculated total peripheral resistance. Remember, that's what we wanted to do. The whole purpose was to get this particular variable right here from our cardiac output and our mean arterial pressure. So if we look at the data points, the first data point in each of these slides is normothermia. That's just when the guy's lying there, doing nothing, resting. And then we've got 2 levels of heating, 0.7 and 1.2 increase in core temperature. So if we look at heart rate increased from about 60 beats per minute onward close to 100 beats per minute when internal temperature elevated to about 1.2. Likewise, cardiac output increased from about 7 to almost 12 liters per minute. Not quite the 6 liters that Dr. Rao saw, but still 5 liters per minute increase in cardiac output. Blood pressure is well maintained, and then here the heat stress alone causes a profound reduction in this total peripheral, or if you will, systemic vascular resistance. And the reason for that is you've dilated the skin so much that there's a net decrease in vascular resistance. So once we got to that point, we applied this simulated hemorrhage, this LBNP, that we've called it now percentage of the hemorrhagic challenge. And as opposed to in the past where we said, okay, this is 30 millimeters mercury, this is 50 millimeters mercury, we quantified this based upon the percentage of time that they were exposed to that hemorrhagic challenge, 25 up to 100%. And 100% is the point at which blood pressure plummeted, and we stopped the test because they were feeling really bad and we didn't want them to faint. So here we go. Heart rate during this LVNP increase, it's very common that you'll see a decrease in heart rate just before somebody's fainting. It's a vagal response. Don't have time to go into that today. We see an appropriate decrease in stroke volume. We see a large reduction in cardiac output. And one thing that we are fascinated with, that a cardiac output when somebody is normothermic, 7 liters per minute, is inadequate when they're heat stressed. Because, come and look at blood pressure. Here's our blood pressure. And this, by the way, this isn't a cuff blood pressure. And this isn't a fingermeter blood pressure. This is a direct catheterization of the radial artery blood pressure. So this is not influenced by some of the other potential errors associated with blood pressure measurements. Blood pressure here, mean blood pressure was 40 millimeters mercury when we stopped the test. So notice, though, that cardiac output of 7 liters per minute is no longer adequate to maintain blood pressure in the heat stress scenario. You need to have this elevated cardiac output. So once again, what's happening down here? This is the whole purpose of the study. We saw an absolute no change in systemic vascular resistance relative to the heat stress. There was no change in here, this end point. And this just baffled us. Here we have a very profound hypotensive challenge to this hemorrhagic insult, but yet we're not increasing vascular resistance. And that's very perplexing. Why is vascular resistance not increasing at a time when blood pressure is plummeting? Which we have, this is what typically happens under normal thermic conditions. That is, if you did not heat somebody and then you applied this hemorrhagic, you'd see a very large increase, which we didn't see here. So the first thing, we have these baroreceptors. These are sensors throughout the body that detect blood pressure and send a signal saying, hey, blood pressure is not high enough, do something about it. And it increases heart rate, it increases nerve activity to cause vasoconstriction, and we spent 8 years trying to identify the effects of heat stress, and just about everything that we've seen suggests that heat stress does not impair this responsiveness. So the reason why we are not vasoconstricting under this hemorrhagic state, it's not because the baroreflex is not functioning. They're functioning completely normal. There's some other mechanism that's causing this to occur. Let's discuss that. What could be going on? Why are we not vasoconstricting the vasculature, which is important to regulate blood pressure? These are some very classic data out of the baboon literature, or baboon model, also from Larry Rao. Instead of systemic vascular resistance, you can take the inverse of that, which is vascular conductance, and from this you can sum up, if you will, the vascular conductances of the individual beds to come up with a total vascular conductance. That's not important. Just think of conductance being the inverse of resistance. So here he said, okay, if we take a baboon under normal thermic conditions, this white area is the vascular conductance of the viscera, primarily the gut, for example, probably the renal bed as well. The black area is the conductance of the muscle. The red area is the brain, heart, etc. I've never known what etc. was. I don't really know what's brain, heart, and etc. You know, I've ran into Larry Rao many times, and I keep on forgetting to ask him that question. What is the etc. in this red box? And then the blue, of course, is the skin. So what do you think happens with heat stress, with these vascular conductances, or the ease at which blood can go through these beds? Well, we talked about already that there's vasoconstriction in the viscera, and that's what's seen here. You can see that there's this reduction in the splanchnic and renal blood flow, which is caused by this reduction in conductance. Muscle, here there was a decrease in this particular model. The brain and the heart really didn't change, which is a bit perplexing because we showed you earlier that brain blood flow decreases. I think what's happening, if you recall, heart rate's going up. So I think you're seeing a decrease in brain blood flow, but I think the heart blood flow, that is blood needed to provide oxygen to the heart, is elevated. And I'm guessing that's why you see this box being no different. But the key point is Look at skin. Huge increases in skin vascular conductance during a heat stress. This blue box here, and representing a very large, essentially a doubling of vascular conductance by the heating. Okay, we're going to go back to this formula. It's the same formula we had before. Blood pressure is equal to cardiac output. And now, because we're looking at conductance, which is the way Larry Rao reported this, I've flipped this. So cardiac output divided by vascular conductance. The same principle applies. So if we decrease cardiac output during a hemorrhage, what do we need to change with respect to vascular conductance to maintain blood pressure? Well, it should be obvious that we need to decrease vascular conductance to maintain blood pressure. Which of these beds would you like to decrease vascular conductance in under this scenario? Do you want to decrease vascular conductance in the muscle? You don't have any left. Look at your reserve. You only have that small box to decrease. So obviously you want to decrease vascular conductance in the skin. You've got this huge bed here that's massively dilated. You want to constrict that bed to offset the reduction in cardiac output to maintain blood pressure. And we sought to identify the effects of heat stress on the capacity of the skin to constrict during a hypotensive challenge. Similar model, this open box here is under normal thermic conditions for arterial blood pressure, and then heat stress conditions. Once again, heat stress really doesn't change arterial blood pressure. And this is the final 100 seconds of lower body negative pressure, that hemorrhage model, or we also included some upright tilt. I think there's like 6 upright tilt individuals, which also causes blood to shift from the chest down to the legs. Here we stopped when blood pressure, in this case, average was 55 millimeters mercury at the point at which they started to feel symptoms associated with fainting in 46 individuals. So clearly the point is that there's a very profound hypotensive challenge occurring here. If we look here at cutaneous vascular conductance, think of this as skin blood flow, or actually skin vascular conductance. This is the big blue bar that we looked at earlier. And here's under normal thermic conditions, and here's other heat conditions. This is that change in that blue bar under normal thermic when it was kind of small, and heat stress when it was really big. That's depicted here. We normalize this relative to 100, and then we apply this suction. And the thought is we should see a very profound vasoconstrictor response. And that's not at all what we saw. Despite blood pressure, if you remember, dropping down to 55 millimeters mercury, there was very little change in cutaneous vascular conductance. And in fact, we calculated only a 15% reduction in cutaneous vascular conductance. So, once again, you got the big blue bar, and you're not constricting it very much. So, if we go back to this model that we have here, we've got all this blood going to the skin. We are decreasing cardiac output through our hemorrhage model. We need to see a large decrease in vascular conductance. In fact, we need it to decrease about 50% or more if we're going to maintain blood pressure. Yes, sir, in the back. Sure. The question is, can you raise the legs under a shock scenario or hemorrhaging scenario to reduce the amount of blood that's going to the skin? That would be beneficial, but by raising the legs isn't necessarily going to take blood out of the skin in the legs. You're still going to have blood in the skin. It will allow for the drainage of the blood that's stored into the legs to go back towards the chest. So yes, it would be beneficial. You would still have much of the other areas of the body that will be at a vasodilated state and will remain vasodilated, and so I think it would be an intermediate condition. And in fact, what they often use in the military is something called MASS trousers, military anti-shock trousers. And they're actually compression garments that they can put on and compress the legs for the same reason as elevating legs, pushing that blood. But that's not just the skin, that's the whole vascular bed in the legs. And we're going to talk a little bit about some mechanisms or some ways that we can prevent some of these things from occurring. So we want this to come here, but yet we only decreased 15%. And that results in a very profound decrease in blood pressure that's not offset by a vasoconstrictor response in the skin. So if we look at an interim summary, what we know so far, heat stress increases skin blood flow and systemic vascular conductance, or decreases systemic vascular resistance. Heat stress reduces tolerance to a hemorrhagic challenge, and during a hemorrhagic challenge while heat stress, there is relatively little cutaneous vasoconstriction despite lots of blood, upwards of 6 liters per minute, going to the skin. Why do we not vasoconstrict the skin? I'd like to spend the last part of my talk addressing that very point. Why is the skin not vasoconstricting? So here we've got a skin blood vessel, and this is skin blood flow, and this would be while somebody is normothermic, much like we are here. Well, if we were to go outside, where it's quite cold, for example, we're going to vasoconstrict or decrease skin blood flow through some neurotransmitters, norepinephrine, neuropeptide Y, that's being released from an adrenergic vasoconstrictor nerve, this nerve on the left. If we go outside in the middle of the summer, we're going to get very large increases in skin blood flow due to a variety of mechanisms that we don't know exactly what the precise neurotransmitters are. I've included some possible candidates here. And this occurs through a separate vasodilator. It's a cholinergic vasodilator, a sympathetic cholinergic vasodilator nerve. So the humans are very unique in that it has 2 entirely separate neural systems governing skin blood flow. And in fact, I don't know of any other, even the baboon or non-human primates do not have this dual innervation. So somebody often says, well, why don't you use a rat model to measure skin blood flow or to assess skin blood flow? Well, you really can't, because the rat model doesn't have the same architecture. They only have one nerve, that is this vasoconstrictor nerve. And so it's really important, in my opinion, to use humans to look at this particular model. A little editorial comment there. So one of the things that we were proposing is that during a heat stress, of course, that there's this large increase in activity of this particular nerve. We wondered if this nerve was somehow inhibiting the response from the vasoconstrictor nerve. Because once again, we want to constrict the skin, but it's not constricting. So we hypothesized that something was being released here that was causing the vasoconstrictor nerve to not function properly, or the response of that nerve to not function properly. And in order to test that, think about this, how would you test that question? Well, what if you blocked this nerve? If you blocked the nerve, you would relieve the vasoconstriction, and then perhaps you would then see an appropriate vasoconstrictor response, which is exactly what we did. We identified a number of years ago that this particular nerve is very sensitive to botulinum toxin, the same thing that you hear for cosmetic purposes, that this botulinum toxin is taken up by this nerve and completely wipes it out. So yes, we brought a bunch of people into the lab and give them Botox in the forearm. So they weren't as happy. We had another protocol, by the way, that we did give it in the face. That's another line of research. And we had tons of people wanting to do that one, of course, mostly ladies. So we gave botulinum toxin in the arm to block this and then see whether we would have enhanced vasoconstrictor responsiveness under these conditions. We employed a technique called interdermal microdialysis. To do this, we take a 25-gauge needle in this case and stick it in the arm, just in the dermal space. We don't really want to go to the subdermal space, but rather in the dermal space. And then we thread a small little membrane through here and pull the needle out, and we get a situation such as this. So in the middle here is a membrane that we can, well, here we go. Here's a picture. So here is this probe, and in the middle is a semi-permeable membrane that we could administer drugs into that migrate out and cause an effect in a particular area. We could then use a technique such as laser Doppler flowmetry to assess skin blood flow responses, or if you want, sweating in that particular area. It's a very powerful way to introduce drugs locally in the skin without having systemic effects. So this is what we did. We have 2 sites. We had the control site, which is the white, the Botox site, the site that blocks this vasodilator nerve in the yellow. We did the heat stress, and once again, if we block the vasodilator nerve, we shouldn't see any dilation. Here's skin blood flow, and we didn't. Notice the control site, very large increases, and at the Botox site, we blocked it. We then wanted to get this blood flow up to here, so we gave a drug, which is called a beta agonist. It's isoproterenol, and we increased it so that we're starting at a similar baseline, and then we applied this hemorrhagic challenge and looked at the extent of vasoconstriction that occurred at the Botox site relative to the control site, hypothesizing that we'd see more vasoconstriction at the Botox site. And that's what we saw. Here we've got cutaneous vascular conductance. Here's the control site, normal condition. And this is in heat-stressed individuals. On the left here is pre, and then this LBNP. Once again, think of this as hemorrhage. We saw about a 15% reduction in blood flow or vascular conductance, just like we saw before. But the magnitude of vasoconstriction at that Botox site, we just lost our signal, was completely abolished. We've lost the video. I still see it here, though. Can you? Do you want to hold that up real high? Everyone can see it? I could push buttons, but I'd probably break something. I expect that at some point. Well, is it? Okay, well, that's okay. Let me do this. Let me go ahead and no, yeah. No, I can go ahead and carry on. Just give me memory jog. So what we saw is when we blocked the vasodilator limb, we completely abolished the, well, not completely abolished, we maximized capacity of this vasoconstrictor limb to constrict. So the take-home message with respect to this is there's something being released from the dilator that's causing the vasoconstrictor limb to not function properly. So we thought, well, what's the mechanism by which that could occur? We know that nitric oxide is very much involved in regulating blood flow. So we did a study where we blocked the nitric oxide by giving a drug through that microdialysis called L-name. And in doing that, when we blocked nitric oxide, we saw massive vasoconstrictor responses. Once again, suggesting that the nitric oxide might be involved in attenuating the extent to which, oh, look at that. That's shown right here. Good. Oh. This is where we blocked the nitric oxide. Look at the vasoconstrictor response was essentially double when we blocked the nitric oxide, suggesting that nitric oxide could be involved in this vasoconstrictor response. The last thing that we did was we gave norepinephrine exogenously when we gave high concentrations of nitric oxide, once again to further this question. So here we've got a nitric oxide site and an adenosine site. This is skin blood flow. We increased blood flow by both of these mechanisms. Once again, this has a lot of nitric oxide. This has some, but not so much. We then gave different concentrations of norepinephrine through this little microdialysis membrane and modeled a dose-response curve, and we get curves such as this. So this solid circle is the SNP, or the nitric oxide site, and this is the adenosine site. And what you can see, for a given dose of norepinephrine, there's much more vasoconstriction. We start out here at 100, and at this 10 to the minus 5, we come all the way down to 20%, whereas when we have the nitric oxide, it's about 60%. So what we think is happening is that nitric oxide is involved in this vasodilator limb that's inhibiting the capacity of the vasoconstrictor system, so that under a profound hypotensive challenge, that constrictor system in the skin isn't working properly. So take-home message, lots of blood going to the skin during a heat stress and very little returning to the core. What can we do about it? How can we help a soldier who is heat stressed and also hemorrhaging? So under normal thermic conditions, we've got a certain extent of blood volume, central blood volume. In the heat, we show those pictures, and we're losing blood volume in the central bed and sending it off to the skin, but we're not bringing it back during a hypotensive challenge when they're hemorrhaging. It's not coming back here. And so you can see if you have less blood volume in the chest, that when you start to hemorrhage, you're not going to be able to maintain blood pressure as well. So we need to get this back. And one way that you can do this is simply what you mentioned. You can raise the legs. Raise the legs, use the mass trousers, which is the whole purpose, and that will help prevent, or that will help to some extent increase the central blood volume. You can simply give them a bunch of fluid. If you give them a bunch of fluid and then fill up this central blood volume, that will be beneficial for blood pressure control, and that's often done in the field, of course. If somebody is having a hemorrhagic injury, they will load them with fluid. Very normal. There's some other problems with that, but that's a different scenario. So we wanted to test that hypothesis. Can we just load them with fluid? So we took the same group of individuals and did a third trial where while they were heated, we gave them a bunch of fluid, sufficient to return central blood volume to normal levels, and that's this greenish line. And notice that our survival curves were completely normalized. These individuals in the green were also heat stressed, showing that if you adequately control central blood volume, you can completely prevent heat-induced reductions in tolerance to a hemorrhagic injury. Now, unfortunately, though, salaine's heavy, and in the field it weighs a lot to transport saline along to give to to a soldier. What other ways do you think you can get blood back to the chest? Sorry, Nicole? Cooling, exactly. If you cool the individuals, you can do it. It's a very profound stimulus, and we've shown this. It overrides any sort of vasodilator response, and you can take blood from the skin and get it to the chest. However, right now, military protocol is all hemorrhaging individuals are heated, not cooled. That's the protocol. They heat individuals because they're concerned about coagulation issues. And they find that when individuals are bleeding, they often become hypothermic, which is a different reason. It's probably because of low metabolic metabolism, because you're not perfusing the blood vessels, so metabolism goes way down, and so temperature goes way down. And they're more likely to die when they're hypothermic. So regardless as to their temperature, they heat the hemorrhaging soldier. And one of the grants that we have now through the military is to challenge this. And what we want, our objective is to get the military to first take a soldier's temperature. And if they are normal or hypothermic, hypo-low, that then let's go ahead and heat them. That should be okay to some extent. But if they're hyperthermic, which we saw in the very first slides, let's not heat them. Let's monitor them. Because if you heat them, you're just going to put more blood in the skin, less in the chest, and they're going to be more likely to succumb to that hemorrhagic injury. I thank you for your attention. I would like to acknowledge both the NIH as well as the Department of Defense, who's funded much of this work over the number of years. And I think we may have a little time for questions, but thank you once again for your attention. Questions? Yes, sir. So the question is, what's the contribution of local heating, if you will, of the skin and vasodilation associated with that relative to the core heating? I believe that's a great question. We know that the skin will dilate by two mechanisms. One is through local induced vasodilation. And remember, skin temperatures under this military outfit was upwards to 38 degrees. And so that's a very profound vasodilator stimulus relative to the core, which is that neural mechanism that we talked about. When we locally cool them, you'll see a vasoconstriction even in a denervated state. So that cooling will remain very effective in improving central blood volume, even in that vasoconstricted state. We are very interested, and we're looking at right now that interplay between core temperature and skin temperature in modulating some of these vasoconstrictor or attenuating some of the vasoconstrictor responses. And it appears that skin temperature is extremely important, not important, has a large influence on the regulation of skin blood flow under scenarios where, of course, skin temperature is high. We did a protocol recently where we did a hemorrhagic challenge with high and low skin temperature, but high core temperature. And that, of course, that low skin temperature was very, very beneficial in preserving tolerance. So I think the local temperature is really important, quite important, in fact.
So you were saying if we're in a situation where we don't have saline available,
Yeah.
we don't have these drugs available, but we do have the ability to cool the body, that will not be a waste of time.
Oh, yeah. Absolutely. It'll be effective. The military is very concerned about hypothermia and the effects of that in blood coagulation. So as long as you're okay with respect to that potential liability, then yes, I think cooling is very important. Yeah. Was there another question over here? Yes, sir. We think it's a major player. Yeah. Sure. So the question is, being that nitric oxide is very much involved, at least we believe it's involved in attenuating the vasoconstrictor response, can we give a pill or a cream or something like that to block the nitric oxide effect and perhaps preserve central blood volume? Fascinating thought. We've thought about it as well. Unfortunately, we can't give nitric oxide or an inhibitor of nitric oxide just in the skin. You're going to give it everywhere when you give it systemically. You can't give it by a cream. It's only available, in fact, it's not even available clinically. It's just used experimentally. So I think it's an interesting thought. At this point, it's really not practical for it to be given. That said, it does increase blood pressure. And so perhaps there's some therapeutic potential, maybe way down the road. I don't know. Yes? Sure. The question is, do we want to address dehydration, which also causes hypovolemia, with respect to some of the responses that we see here? We know that when we heat stress individuals, and likewise these soldiers, they're becoming dehydrated, and that's going to cause some adverse responses. We did a protocol, either the paper has been accepted or will shortly be, or is in the review process, I don't recall which, where we gave saline, titrated saline during the heat stress to counteract any fluid loss that occurred during lower body negative pressure. And when we did that to the hemorrhagic challenge, we saw a partial preservation of lower body negative pressure tolerance. So we do know that the dehydration that occurs during the heat stress contributes to a small extent, but we were nowhere near back to a normal hemorrhagic state or protection. If I was to put a number on it, I would say perhaps no more than 25% of the decrease in tolerance to hemorrhagic injury to heat is caused by dehydration that occurs during that particular heat stress. We've got another protocol right now where we're looking at hydrated versus dehydrated individuals during exercise in a chamber, with the idea is if we have a soldier who is marching for an hour and a half and doesn't get adequate hydration relative to if they do, what's the impact of that on tolerance to hemorrhagic injury? And we've only done one subject. We've done all the subjects at one limb and only one in the other, so it's too early to tell. I'll tell you in 6 months, what happens. But hydration obviously is important component. Matt? It's a great question. So the question is with more females being permitted to be in combat roles, as well as changing requirements, loosening the requirements for body mass index, presumably more heavier individuals, Is there some role that those might play? Let's start with the females. We know that females are more susceptible, at least to an experimental hemorrhagic injury. So if we do this upright tilt or lower body negative pressures, as a group, females will experience this presyncope earlier than the males do. I don't know how that translates to an actual hemorrhage injury. We're quite interested in looking at that, but to do that, we actually have to draw blood out, which we can do. We're going through the process, but not too much blood. So I don't know the answer to the first question, except that females do, at least with this model, are more susceptible. So presumably they would be more susceptible to a hemorrhagic injury. The second one, perhaps I should have you answer the second question. With respect to obesity, with that being an interest, my recollection of your data is that we didn't see much of a difference in the obese individuals with the capacity of them to tolerate a hemorrhagic injury during LBNP in the heat, which would suggest that that would not necessarily be a problem. Although they might get hotter. Yes, sir. Sure. Yeah. So the question is rather than adding saline, should we add something else like a protein? What I didn't say is in all those protocols that we did, we actually gave a high colloid solution. We gave a dextran or a head-of-starch solution, which is actually used often in the military. So saline itself is used, but they will also give a high molecular weight solution. And the purpose of that is if you give saline, it rapidly leaves the vascular space. But if you give saline plus a high molecular weight substance, like albumin, some sort of a carbohydrate, I think it's a carbohydrate solution, that has a higher oncotic pressure, and it keeps the fluid into the vascular space, which is common. So yes, we've thought about that, and that's actually quite effective. In fact, one of the first protocols, we didn't do that, and we had to give, 2 to 3 liters of saline to normalize central blood volume, whereas we only needed a liter of a head-of-starch or dextran type solution. Yes? So the question is, if you give a fluid, and I think the point is valid, let's not think of saline, let's think of like a high molecular, but regardless, a fluid and the impracticalities of that because of the weight, what about the practicality of cooling? And I have to say, you got me. You caught me. Try to get that under the table there. It's a problem. How do you cool an individual where it doesn't cost a lot in the way of manpower and equipment? And there really isn't, that I know of. And there are, like Peltier-type devices, which can be heavy. You need to have electronics to cool individuals. It would be interesting, perhaps, like something like a menthol cream or something to put on the individual that could cool the skin. Perhaps that might work. I guess the point that I want to make, and perhaps by saying cooling it's going a little bit over the top, is that we shouldn't be heating them. And that cooling clearly is best, but we don't. I'm not aware of a way that we can effectively cool them with something that a soldier can pull out of a little bag and say here. Particularly when it's 115 degrees outside, ice isn't going to work real well. It's not going to stay frozen. There's nothing else. Thank you for your attention.